Greetings and welcome everyone to our second annual Dr. Erik Fleming lecture, where our goal is to honor Dr. Erik Fleming's legacy through engaging discussions around health disparities, place-based research, and also policy to advance underserved and under-resourced communities. At this time, I would like to introduce the president and CEO of Charles R. Drew University of Medicine and Science, Dr. David Carlisle, who will provide a welcome and opening remarks. Thank you, Dr. Carlisle.
And thank you, Dr. Partlow. And I just want to say welcome, of course, to all of our attendees, particularly the Fleming family. And I'm thinking of EJ, who I know is with us as well, Erik Fleming's son. Thank you for joining us for the annual Erik Fleming lecture. And you know, it's with immense pride that I'm happy to welcome everyone to this lecture. We all, most of us knew Dr. Erik Fleming, and he was taken away from us prematurely, too soon, but he made major contributions to our society and our institution. Erik Fleming was a researcher, somebody whose work I was very familiar with because he used a lot of the data and research methodologies that I myself had used and focused on the same questions. In fact, his focus on disparities allowed him to make a permanent contribution to the legacy of Charles R. Drew University of Medicine and Science. And this is our vision statement: excellent health and wellness for all in a world without health disparities. That last phrase, in a world without health disparities, was specifically coined by Dr. Fleming. I remember being in a large meeting where he basically raised his hand and he said, "What about this?" And at that point, the light went off for everyone. And now we have our vision statement that provides the guiding North Star to our institution as we go about the activities of the day-to-day work of our university. So Dr. Fleming made significant contributions to our institution, made significant contributions to our society, and of course, has connected us to his great family as well. So with no further ado, I want to also welcome our guest speaker, Dr. Anthony Watkins. I know that he's going to be introduced by Dr. Partlow, but I want to say thank you very much for joining us on this most auspicious and important occasion for our institution. Thank you, everyone, for being here.
Thank you very much, Dr. Carlisle. At this time, I would like to introduce our featured guest today, Dr. Anthony Watkins. Dr. Anthony Watkins is an experienced board-certified surgeon who specializes in abdominal transplant surgery, and he's also the surgical director of the Kidney and Pancreas Transplant Program at Tampa General Hospital in Tampa, Florida. He has an amazing background and training, including authoring several publications and book chapters. His current research interests include disparities in medicine, increasing access to transplantation, and also surgical education. Most recently, he was recognized by Super Doctor as a New York Rising Star, and also a recipient of the Top Healthcare Professionals Under 40 Award by the National Medical Association. He's also frequently recognized as one of America's top doctors, an honor given to the top 1% of all physicians in the country. Ladies and gentlemen, please join me in providing a warm welcome to Dr. Anthony Watkins. Thank you for being here today, Dr. Watkins.
Thank you. And good afternoon, everyone. Yes, it's now noon there. Share my screen. Everyone can see this, correct?
Yes.
Okay. So I'm honored to be able to participate in the annual Dr. Erik Fleming lecture. Erik was my uncle, and this picture here is actually at the NMA conference in Hawaii in July 2019, and I just had the pleasure of hearing him present some of his work. And so my hope is that I can make him happy as I kind of discuss um, the role of COVID-19 and healthcare disparities and how they've impacted on what I do in my day-to-day clinical practice, which is transplantation. I have no financial disclosures to disclose. So just a quick timeline of COVID-19 is to go back. If we recall, back in December of 2019, there was a mysterious illness in Wuhan, China, that we were all kind of looking at from a distance and wondering what exactly was going on. By June of 2020, the first US case had occurred. And by March of 2020, this disease had become known as a pandemic. And we kind of all are familiar with what happened in those months and that followed. If you look at the global outbreak evolution of COVID, United States has consistently had the largest number of confirmed new cases in comparison to other countries. This is obviously multifactorial, but it's important to note, despite the time period that has existed between this initial diagnosis of this new problem and now, you see that back in January of this year, we had over 800,000 new cases in the United States. Fortunately, these new variants are not as causing as much mortality, but it's still an issue that we grapple with day to day. So when you look back at either origin or our first response to COVID-19, the quarantine became one of the instrumental tools to try to keep things at bay. But this is also where we first began to see some of the disparities of COVID-19 become apparent in the United States. This is because as a large group of society was able to quarantine, there were the essential workers, which not only included physicians, but also policemen, et cetera. These workers were still working, and their responsibilities in some cases actually increased. For example, physicians such as myself were redeployed to ICUs to help out with the burden of COVID-19. And this is when we started to see some of the disparities become apparent. So, for example, if you look at New York City, and then for those of you who are not familiar with this map in the city, I'll kind of show you this. This right here is the island of Manhattan. This is Brooklyn. This is Queens, and this is Staten Island. And the darker areas are where there are the highest number of positive COVID cases. If you look at where the service workers tended to live, you notice some overlap in regards to the number of positive cases. And then when you also look at the rent burden households and where the largest number of people of color lived, you see that there was a apparent correlation between the positive cases and where people of color and service workers lived. When you take a closer look at why certain groups were at a higher risk for COVID-19, it became apparent that this is because Black workers, for example, were more likely to have pre-existing health conditions. They had limited access to healthcare. They were more likely to live in multi-generational households with dense housing. And this is also part of the reason why New York City, had a large burden of early diseases because of the way people lived and moved within this geographical area. The frontline people, Black workers tended to be frontline industry workers. They lacked health insurance, and they lacked the ability to work at home. And they also, would commute to work via public transportation, which obviously put them at risk for exposure to this disease process. When we look at the deaths of COVID patients, looking at the state of Illinois, Michigan, and Louisiana, we also see disparities in the number of African Americans that were dying due to COVID, particularly in relationship to the percentage of the population they made up. So, for example, if you look at Chicago is roughly 33% of the population is African American. However, early data show that 50% of confirmed cases were within African Americans, and as high as 72% of the fatality rate was in African Americans. If you look at the state of Michigan, while African Americans made up 14% of the population, 33% had the confirmed cases and 40%. In Louisiana, you see that same disparity. So not only were we seeing a higher incidence of these cases, but we also were seeing a higher incidence of COVID-related deaths. So one of the reasons we were seeing this stark contrast is because prior to the COVID-19 pandemic, we were really dealing with another public health crisis, which is systemic racism and its impact on people of color and their disparities in various health conditions. The National Institute for Healing and Justice uses this figure to kind of describe the complex mechanisms within racism and how they affect healthcare. And they're important to note that it's racism, not race, that causes health disparities. So, for example, structural racism is the creation and perpetuation of systemic disparities via mutually enforcing societal norms and overarching structures that together shapes society's fabric. You have institutional racism, which perpetuates the systemic disparities via discriminatory policies. You have the cultural racism, which is a belief that there are generalized intrinsic cultural differences belonging to individuals of one race or ethnicity. Interpersonal, which is the behavior and communication between individuals based on unfounded negative attitudes about one's race. And if you've ever read Malcolm Gladwell's book, Talking to Strangers, he really does a good job of breaking down this interpersonal racism aspect. And then finally, you have internalized racism, where you're maintaining or participating in the set of attitudes, behaviors, et cetera, that support the power of the dominant group. And equally important is the social determinants of health, which is those determinants of health that's based on where an individual lives, works, and how it affects their health outcomes. So you have, examples include economic instability, how much income a person makes, where they're employed, obviously their housing and the transportation that's provided within their community and access to playgrounds, education, which is by far the most critical aspect, because the educational attainment has really shown to be a significant marker of health outcomes. But individuals' early childhood education, whether or not they have their health literacy, obviously access to healthy food options, and the social context and the healthcare system, all of these social determinants of health are equally important into determining the patient's mortality, their morbidity, their life expectancy, and healthcare expenditures, et cetera. So I want to talk about redlining, and I'm going to show a quick video that's talking about redlining. If you're not familiar, but I think there might not be any sound, so I'll talk about it. But redlining is the practice of purposely denying mortgage loans to people based on a borrower's race or where they live. Historically, this has affected mostly people of color living in predominantly minority communities. Banks, realtors, and even the government used red ink, which is where the redlining term comes from, to outline areas on maps where lenders should steer clear. And this practice was common for decades in some of America's largest cities, including Chicago, New York, and Miami. And today, federal law, including 1968 Fair Housing Act, makes it illegal for lenders to refuse a mortgage based on race. Yet, while redlining has largely been stamped out, its impact on communities of color still persists today. And many neighborhoods where redlining was common decades ago remain poor, with lower median household income and house prices. And fair housing advocates also see lenders sometimes improperly deny loans to people of color. And you've probably heard also stories where individuals who are selling homes, if there's artwork or pictures that suggest the race of the family selling the home, this can impact the value that's assigned to their home. And there's been cases in Connecticut and Minnesota as examples of still unfair lending policies. So the reason I wanted to talk about the redlining is because, as that video highlighted, the impact of that is still felt today. So let's take the city of Chicago as an example. And this first block is basically breaking down the ethnic background of individuals throughout the city of Chicago. And it's kind of hard to see, but the blue dots and the red dots are the Black and Hispanic communities. And then if you look, let's first look here, the prevalence of high blood pressure and diabetes. And I mentioned those two because these are two of the most common causes of end-stage renal disease, which leads to the need for kidney transplant. And if you look at the incidence or the prevalence of high blood pressure and diabetes, it tends to be located in those same areas where there's a larger Black and Hispanic community. And then finally, when you look at the COVID-19 hot and cold spots, blue being the cold spots and obviously red being the hot spots, again, you tend to see a correlation with where COVID hotspots existed in Chicago, where redlining practices had forced certain ethnic groups to live, and also where the prevalence of high blood pressure and diabetes coexisted. So you see an interplay of the impact of redlining and how it's the social determinants of health have played a role not only in certain disease processes, comorbidities, but also COVID-19. And then we will look at the vaccination sites within Chicago as of March of 2021. You see the exact opposite in regards to the number of vaccination sites located, again, in areas where Black and Hispanic individuals live. So this is demographic data as of March 2021. And you see where the Black and Hispanic individuals kind of live with the orange areas. And you see the light area is very sparse vaccination sites, where the deep blue is where you had more vaccination sites. And this is where more of the Caucasians lived. And then also, if you look at Ohio and kind of look at the various aspects of COVID in comparison to the population, this is Hamilton County in Ohio, you see that the population is 69% white, 28% Black, but the hospitalization rate was much higher for Black or African Americans. Fortunately, the death rates were more equal to the percentage of population, but the vaccinations were also, you see a stark discrepancy in number of vaccinations that were provided. Now, we also know that there were other factors that play a role into individuals getting vaccines, such as vaccination hesitancy. But this shows the disparities in the population and the people getting COVID and receiving vaccinations. So as we switch over to transplant, this is highlighting the transplant disparities in African Americans, but it's also applicable to the Hispanic community. And you see various issues that have been notoriously recognized, dating well back into the 1970s, when a well-known transplant surgeon in Washington, D.C., Clive Callender, did some very remarkable research showing these disparities. And some of the issues that result in disparities within our community include, number one, genetic etiology. There's something called APOL1, that's a gene mutation that has been shown to provide benefit and protection from an infection in Africa, but it does tend to lead to a higher rate of kidney failure. There's obviously the social determinants of health that I discussed before that leads to a higher incidence of high blood pressure and diabetes. And then when patients are evaluated for transplant, there's some clinical implicit biases and poor communication that can come into play. For those patients out in the community who are in need of a transplant, there's a lower rate of referral to a transplant center. There's poor access to timely donation or even healthy living, which I'll talk about later. And then finally, obviously, the health insurance plays a role. So the issue in transplant is one of a supply versus demand. So there's over 100,000 people on a waiting list for transplants. And if you look by organ in 2020, looking at those individuals who are in need of a transplant and those who receive, the kidney is the most commonly transplanted organ. So that's why this figure shows a large number of people waiting. But although in 2020, there was almost 100,000 people waiting, only roughly 20,000 were transplanted that year. The disparities aren't as large for the other organs. So I'll kind of focus, on this kidney aspect to kind of highlight the disparities. But it shows you that for all comers, there's a huge issue in between the organ supply versus demand. Then when we break down the race of individuals who are waiting for organs, you see that while Blacks make up roughly 13 to 15% of the population, they make up a large percentage of the individuals who are waiting for a kidney transplant, which is here in red. Same goes for Hispanics, whereas the white people are not as large in comparison to the percentage of people that they make up in society. So this is looking at how racism. Sorry, let me go back here. This represents the transplant journey of someone who's getting evaluated for a kidney transplant. And at each step, it highlights the attrition, where attrition can occur, or hopefully re-entry into the transplant process, and how the structural racism, institutional racism, internalized racism can play a role. First and foremost, when patients are in the community, you want to have preventative medicine in place to provide a lifestyle modification, identify people who are at early risk, and provide modification in their lifestyle so they can prevent the progression of their kidney disease. If they do develop chronic kidney disease and they need to be referred to a nephrologist, who then refers them to transplant to allow them to get evaluated and listed and ultimately get transplanted. But as this figure depicts, at each stage, there's opportunities where structural racism can come into play and result in the patient leading to just dialysis and remaining on dialysis long term. Whereas we know that if you look at patients who get a transplant versus stay on long-term dialysis, the patients who receive a transplant have longer survival. They have a better quality of life because they're not getting dialysis 3 times a week. And so the gold standard of care is for them to get a transplant. But some of the ways these different types of racism can come into play is, the type of health insurance, the burden of disease that prevents the availability of healthy living donors. Let's say for your Spanish-speaking population, there's cultural and linguistic issues that can come into play when a provider is trying to communicate with that patient in regards to their health and providing their options. The institutional racism aspects also can come into play with differential transplant referral rates, based upon stereotypes or cultural assumptions. What if a person presents to get evaluated for transplant and their care provider is unable to come because they're at work, and the transplant center then feels that they don't have an adequate support system, things such as this. And then finally, internalized racism, where an example includes patient concerns about medical mistreatment and bias based upon historical and current experiences of interpersonal racism, limiting willingness to accept medical diagnoses. And this is huge because we are aware that there are some historical aspects or historical events such as the Tuskegee experiment that to this day make individuals reluctant to trust in the healthcare system. And then when you look at patients who receive a kidney transplant and you look at their graft loss, you see that the way we look at graft survival in the transplant world, is 1 year, 3 year, and 5 year graft survival. So and then end of follow-up. And then so this is the event rate, this is the graft loss percentage, and this is African Americans versus white. So if you look at the death since graft loss, you see that there's a significantly higher graft loss rate within African Americans at all time points, both 1, 3, and 5 years. in comparison to Caucasians. Fortunately, the mortality, meaning patients, dying as a result, is not as significantly different, but this still highlights that not only are we having a higher rate of kidney disease and a lower rate of getting transplanted, but then when we get transplanted, the outcomes aren't as good. I wanted to put this data up because living donor transplant provide the best outcomes, because the organs from living donors, which are family members or friends, tend to work immediately and last much longer than the deceased donors. But if you look at the incidence of living donor kidney transplant in 1995 versus 2014 by race, you see that while whites had an increased rate of living donors within their community, the blacks, the African Americans actually decreased from 3.4 to 2.9%, and Hispanics actually dropped as well, whereas Asian population stayed relatively the same. So this is leading to a lost opportunity to receive an organ transplant from a donor, which will provide the best outcomes within our communities. So when you look at the racial disparities in liver transplantation, this is one study that was published last year, and I wanted to give another example of some of the challenges that exist within our community. So this paper sought to correlate the transplant center characteristics with patient access to waiting lists in liver transplantation. And what they did is they looked at all the transplant centers who did deceased donor liver transplants from 2013 to 2018. And for those high functioning centers, those centers that performed over 250 transplants over this period, they compared the race and ethnicity of their waiting list to the community in which they were providing care for. So for example, this would be taking a center such as UCLA and looking at their waiting list, and then looking at the surrounding community to see if there was a disparity in the number of people within the community who needed a liver transplant versus those who were actually getting on the wait list and getting transplanted. And what they showed, which was pretty remarkable, out of 81% of these centers, and again, these are high functioning centers, non-Hispanic Blacks were underrepresented in 81% of these centers. Non-Hispanic whites, in contrast, were overrepresented in 58% of these centers, and then Hispanics were underrepresented in 62% of these centers. Now, this is important because in theory, you would think that if a center is located in a certain population, that they will naturally be transplanting more of the individuals that they're representing, so to speak, but this is not the case. Now, the reason why I want to talk about COVID, because then we want to see, well, what role did COVID, play in transplant, and what impact did it leave? So obviously, as you can imagine, because organ transplantation requires us providing patients with immunosuppression medication to suppress the immune system to accept an organ, we, at the beginning of this pandemic, the majority of centers, 51%, had a reduction in their deceased donor transplantations. 72% completely suspended living donor kidney transplants, right? Because the idea was, well, if you're having a healthy living donor come into the hospital, you don't want to put them at risk of getting COVID-19, even though they can provide a better outcome for their intended recipient. And 84% of transplant centers had some level of restrictions. So let's take a closer look at this. I like this figure because it looks at solid organ transplant. It looks at organ transplant activity by state level incidence of COVID-19. So as on the y-axis here, as the cumulative incidence of COVID increased, what type of restrictions did centers put on the types of transplants that were performed? So this LDKT, this is living donor kidney transplant, deceased donor kidney transplant. So these are patients who are brain dead. This is living donor liver transplant, deceased donor liver transplant, then obviously pancreas, heart, and lung. No transplants means these centers shut down. And then there were some restrictions in red, no restrictions in blue. So immediately you notice that living donor transplantation, for the most part, whether it was kidney or liver, there were no transplants performed, regardless of the incidence of COVID, because we didn't want to put patients at an unnecessary risk. And this is primarily referring to the living donors. And then pancreas as well, for the most part, had a large number of no transplants. Then what you see is the majority of programs had some level of restrictions, which is represented by the red dots. And then very few programs had no restrictions, but obviously as the incidence of COVID increased, you see some changes in the program's responses. But again, this shows how the impact on all transplant centers of transplantation, there was at minimum at least some restrictions that were put in place, which hurt access to transplant for a lot of our patients. So what are the factors that limit transplantation? Well, number one, as you heard in the media, there was a decrease in available ICU beds. So you had a shift in ICUs being taken over by COVID patients, and even makeshift ICUs being created in several hospitals. At the time, I was still working in New York, and there were makeshift ICUs all over. And as I mentioned before, all physicians were redeployed to kind of work in these environments to help out with the burden. The demographics of available donors shifted. So people are quarantined, right? So what you saw was a shift from traumatic accidents, motor vehicle accidents, falls, even, gunshot wounds, et cetera. Those types of donors went down, whereas the substance abuse went up, right? So now people are at home, they have nothing to do. So the substance abuse went up. There was a decreased willingness to use donors in whom post-operative transplant recovery anticipated to be prolonged. So what this means is that we didn't want to transplant patients with the anticipation of them remaining in the hospital for long periods of time, which we felt that would increase their risk of getting COVID and affect their outcomes. And then donors with potential COVID exposure were excluded, right? Because we didn't have the data. We didn't know if there was going to be a huge risk of transmitting COVID through the organ transplant process. And you also finally, you had a shift for programs not, oftentimes in transplantation, we share organs across state lines. And what we saw a shift was within our community is a preference for using local organs where COVID rates were known. So this study kind of looked at the initial report, looking at those patients who were transplanted and who developed COVID. The initial outcomes of those patients, and what it did show is this was solid organ transplant recipients at 2 centers in New York during the first 3 weeks of outbreak of COVID. This study looked at the baseline characteristics, the clinical presentation, the immunosuppressive management, and compared it between patients who had mild or moderate versus severe disease, which was defined as ICU admission, intubation, or death. And what they showed is there were 90 patients who were analyzed with a median age of 57 years. 46 were kidney recipients, 17 lung, 13 liver, 9 heart, and 5 had dual organ transplant. The most common presenting symptoms were fever, cough, and dyspnea. 24% had mild disease, 46 moderate, and 30% severe disease. And out of the 68 hospitalized patients, 12 required non-reviver, and 35% were intubated. And 16 patients died. So this was 18% overall. It was 24% of the hospitalized and 52% of the ICU. And then a half of the patients who were discharged. So this study showed that transplant recipients, this is one of the first studies to highlight the transplant recipients, as we would have expected, who got COVID-19 appeared to have more severe outcomes than the general public. When you look at heart transplant data, you find some similar disturbing findings. This study out of Michigan was a retrospective case series that looked at patients between March and April of 2020. And they looked at the clinical data obtained through the review of the EMR. And they identified 13 patients who had a heart transplant who were admitted with COVID-19. Mean age was 61, and 100% of these patients were Black males, and symptoms began roughly 6 days before admission. And here's a list of the 13 patients. The blue highlights time that was spent in the ICU on mechanical ventilation. The red is acute care, but the point is, as I mentioned, there were 100. All of these patients were Black, and there were 2 patients, which was 15%, died during hospitalization. So this was one of the many studies that showed similarly worse outcomes with people of color who had received an organ transplantation. So what about kidney transplantation? This study here looked at UNOS data through April of 2021. And what they did is they looked at the people who are on a waiting list for a transplant and those active transplant recipients. And they were looking at those individuals who either died on a waiting list or died after receiving a transplant, and compared those deaths in 2020 to pre-COVID cohort in 2020 and 2019 to see what differences existed. So, for example, this section here are the people who were on the waiting list, and it was 134,000. They found that 11% of deaths in 2020 were due to COVID. And out of those deaths, 72% were male, 53% were obese, 85% were non-white. And this is in comparison to 2020 and 2019, where you see different statistics. And then similarly, when they looked at the recipients, these are the individuals who had been transplanted and ended up dying due to COVID in 2020. These individuals tended to be a little younger, actually. So if you look at the age, median age is 65, here is 68, 68. So they're a little younger. They were obese yet again, and 70% were non-white in comparison to 46 and 41% of the people who died in the years prior who didn't have COVID. So this is yet another example now within the kidney transplant world of patients having people of color having a higher mortality rate, either waiting for a transplant or after they receive the transplant. So what are some of the remaining issues that we have? Well, we now know that COVID has transplant patients have worse outcomes after they've received a transplant and received COVID. So this is why vaccines are important. However, while some transplant centers mandate vaccines, some don't. And as you can imagine, there's a lot of controversy around that. But the important message here is that when you're taking a very limited supply, you want to ensure that those individuals who are receiving a transplant have the opportunity to have the best outcomes. And obviously being vaccinated provides that level of protection to provide better outcomes than if you're not. And then what about the number of doses? Well, as we know, the general public needs booster shots in addition to the 2 initial doses of COVID. And obviously, time will tell how many additional vaccines will be needed. It's likely that the requirement is likely to be annual. But in the transplant community, it's been known for quite some time that our patients need more doses of the vaccine to elicit the appropriate immune response. So transplant patients have to get 4 doses of the vaccine instead of the 3 to the general public. And there's still some question as to whether or not that is adequate. And what about utilizing COVID positive donors? So initially, as I said, the transplant rates went down because transplant centers naturally were reluctant to use donors who were COVID positive. Well, now a lot of centers, including our centers, are using COVID positive donors for transplant. Initially, what we would do is we would use something called the cycle threshold to let us know what level of viral load is present. And if it was higher than a certain level, then it would be safe. If the virus was lower than a certain level, then we can use them. But now we're, as COVID is evolved into these variants that are not as lethal as the previous, the Omicron not being lethal, we're actually opening the doors. We started this about 3 weeks ago, where we're just going to use all COVID positive donors with the appropriate consent, informed consent to the recipients, and ideally in patients who have been vaccinated. What about transplanting COVID positive recipients? This is something that we're still reluctant to do, because as the data that I showed highlighted, even if the general public has better outcomes with these variants, our patients are immunocompromised, which does put them at an additional risk for negative outcomes. So we're reluctant to use transplants or transplant COVID positive recipients, but it's important to highlight that this is something that we are discussing within our community. And then finally, as the FDA authorizes new medications such as monoclonal antibodies for pre-exposure prevention, one of our strategies is to give patients these medications after transplant to provide some level of protection for a period of time so we can improve our outcomes. So what are some strategies to advance health equity? And this will be the final section of my talk. So it's first important to note that race is a social construct, right? But we in the scientific community have to acknowledge that race is a study variable, generally reflects that social definition versus defining race biologically, anthropologically, or genetically, right? And what about the NIH? Funding institutions like the NIH, they should start prioritizing and invest in research that looks at the impact of racism on discrimination and its impact on access to transplant and clinical outcomes. And then we also have to look at the membership of institutional review boards and scientific teams that are performing research and that are reviewing journal articles. Diversity is important, and because the diversity of ethnicity contributes to diversity of thoughts, and it provides an opportunity for us to have a seat at the table, so to speak, in regards to helping approve and devise research that would be important to tackle some of these issues that we face. And then from a clinical practice, community, and policy advocacy standpoint, we need to address the implicit biases and acts of interpersonal racism. Within the transplant community, this involves educating our coordinators, our social workers, to be cognizant of some of the biases that they might have towards certain groups when it comes to, as I mentioned before, their support system. So what program in Northwestern has done, and we recently done here, is devise a Hispanic transplant program where you have a group of individuals who are culturally similar to that community, who are able to speak that language, to provide an opportunity to reduce some of these biases that exist. These similar programs have been created for the African American community. So one of our goals later this year is also to implement something like that. And that will tackle the discrepancy or the disparities in the number of individuals who have end-stage kidney disease within the community versus the ones who are actually getting listed and transplanted. And I showed you that liver data, but there's also data for every other organ where there's a huge disparity in the number of individuals within the community who have these types of disease but are actually getting transplanted. Next is to move beyond that private versus public insurance, because there's a lot of obstacles that this creates, as you can imagine. And not only diversity in IRB and scientific boards, but what about diversity in the healthcare field? This is why it's important for individuals in the audience to become physicians, become scientists, and hopefully become leaders within our field, because then you can provide that vision and help make necessary changes through that position of power to eliminate and to create some policies to help our communities, which would lead to eliminating biased processes and eliminate the persistent health disparities. I thank you for your time, and I'll be happy to answer any questions at this time.
Thank you very much, Dr. Watkins, for a terrific presentation. At this time, we encourage all questions. We definitely have some time. I noted while you are thinking of your questions, I want to note Dr. Abraham in the chat box mentioned being so proud of CDU Street Medicine, Kedron, global team's work to tackle equitable vaccine distribution in LA County. So I definitely want to note that. Thank you, Dr. Abraham. Let's see, Mr. Patton.
Thank you so much for something that was outstanding and enlightening to me, although I couldn't keep up with all the terms, being a legal doctor instead of a medical doctor.
Okay.
What is at least mildly amazing to me is that people have to continue to identify racism, not race, but racism, as a clinical factor in some of these outcomes. Is there pushback in the intellectual and academic community about that, or is that something that we can now assume everybody agrees on, and it's the solution that we can't agree on?
Wow, your question is timely. So I recently relocated here to Tampa to lead the renal transplant program. And prior to my arrival, this Hispanic transplant program had been in the works, because as you can imagine, similar to LA, Florida has a large Hispanic and Latino community. So we had a town hall meeting last week, and one of the Latino nephrologists was talking about the program and what its goals are and how it's going to be designed, and provided an opportunity for people within our program to ask questions, and the response was mind-blowing, because there was even physicians who were questioning its need, right? So I'm sitting there saying to myself, it's 2022, and the data has been there. I mean, like I said, the data has been there since the 70s, within the transplant community in regards to disparities. But there was a question from a physician that said, well, why do we need to create a program specific to a group of people? And so my answer is yes. Unfortunately, there's still a level of ignorance. I think it's probably the best way to look at it in regards to these disparities, why they exist, and why there's a need to be intentional about coming up with solutions to address them, right? We're at the point in the history of our country where, in my opinion, we have to stop talking about it, but we need to be very intentional about addressing it. So unfortunately, yes, there's still room for educating individuals. And in fact, my after that meeting, which was Friday, now my goal is to present to the program, some data similar to what I discussed here on the percentage of people, not only in our country, but within the community in Tampa, because there's a large percentage of Hispanics and African Americans who have end-stage renal disease. But if you look at the number that are being transplanted, particularly in comparison to other ethnic groups, it's a huge disparity. It's huge.
Thank you. Dr. Vargas?
Great. Thanks, Kiyoshi. And thank you, Dr. Watkins. This is an incredible presentation. I think it's timely. I think the overlap with the COVID disparities and what we've known for so long with transplant disparities, unfortunately, is just going to exacerbate some of what we've seen because of the social factors that are driving both of these. We've recently here at CDU done a series of focus groups with people who are either transplant recipients or donors about the use of paired donor exchange and the chains. It suggests that the literature is driving that makes living donor transplants more accessible, but also that this is not being equally shared, particularly amongst African American patients. Could you speak to this and other potential interventions to reduce disparities, and whether you see some promise and things that you can do in your role to help promote those?
Yeah, that's very, very great question. And I'm glad you raised that topic. First and foremost, the race of an organ donor and a recipient doesn't matter, right? So a Caucasian can donate to a Black person, et cetera. But what is relevant is that there is a decreased organ donation rate within our community, which as a byproduct minimizes the number of organs that we can potentially be compatible with, because there is some, there are some ABO and HLA compatibility aspects that when you have more people from the similar backgrounds, you'll have better matching, right? So that's the first issue. We have a decreased number of people interested in organ donation. Then, as I mentioned, we have a decreased number of individuals who are healthy enough to be organ donors, because these same social determinants of health are not only affecting recipients, but they're also affecting potential donors. Now, living donation, as I said, confers the best outcomes. So, and a third of patients who typically come with a donor are incompatible, either blood type or HLA wise. So the kidney paired exchange program provides an opportunity to still provide that potential recipient with a living donor, albeit someone through swapping, right? So that donor will donate to someone else, and someone else's donor will donate to that recipient. And I'll even mention that there's even research and there's even a thought now that even if a recipient comes with a donor that they're compatible with, if we put all pairs within this national kidney exchange system, we can improve the matching by providing a recipient with a donor who's even better matched, let's say in another state. And there's a potential role for that. What I've noticed within our community is that, number one, the recipients tend to be a little bit more reluctant to use potential living donors. And I don't know there's multifactorial, but I'll just say for my 10 years of doing this, people from under or people of color tend to be more reluctant to have people who have expressed interest in donating come forward, number one. Number two, if they do have a potential donor, they're more reluctant to participate in a paired kidney exchange. The reasons I think are similar to some of the other issues with the mistrust, et cetera. It's like, if I'm not giving you my kidney, then, they feel like then that gets a little bit too complex for their desire, what have you. But what my role is, is number one, to educate, repeatedly educate the potential candidates that I see about the utility of the living donation, and then really have that conversation. If there's some reluctance, I probably will go that extra step to have that conversation that other providers will probably, just give up on, and kind of really explain that, look, you can get a transplant sooner. This kidney can last immediately, can work immediately, and this can get you off dialysis, get you back to a better quality of life. And then I think the other piece is just really educating, through whatever form is possible, whether it's going to dialysis centers, whatever efforts you can. I've done a ton of clubhouse conversations. I think it's on the providers to really educate our community, and hopefully that can move the needle, because information and knowledge is power, and hopefully that can get people to be more receptive to kidney exchange and living donors.
Thank you.
Thank you. Thank you very much. And let's see, I see that we have about 3 more minutes. Let's see, we have time for one question.
Yes.
And there is a question in the chat box, and Dr. Abraham, I see that your hand is also raised. So let's see, I see a question from Marshall Williams. Do you think ivermectin and hydroxychloroquine would have changed the outcome of many COVID-19 patients? It was banned because of EU protocols.
Short answer is there was never any data to suggest that ivermectin or hydroxychloroquine were definitively effective. So no, I don't think it would have changed the outcome.
Great, thank you. Let's see, and Dr. Abraham.
Yeah, it's a complicated question, so we probably don't have time for it, but we know that some of these health equities are actually disparities are baked into the whole national organ donor system. So clearly, as you mentioned, advocacy and policy are going to be important parts of the solution. My mother is a kidney transplant patient in Houston. And so we know that there are people that game these systems. They try to make them as fair as possible. But as you mentioned, clearly, Black and brown patients are the ones who aren't always able to meet that threshold of all the supportive care that are required to stay on the list to meet these requirements. So clearly, given the supply challenges of organs, just as we saw recently from other mammal models or maybe artificial innovations, do we see that maybe being a solution to bringing equity to organ transplantation by artificial kidneys or using animal models for transplantation?
Yes, and I was actually, so prior to coming here, I was at NYU, and if you're aware, I was there in September of last year when the first successful kidney transplant was performed. Because I want to specify pig kidney because roughly a couple of months later, a successful pig heart transplant was performed. So this is xenotransplantation, which is something that has been researched for decades, and quite honestly, up until recently, if you would have told me that that would be possible within my lifetime, I didn't think it was. But what we've been able to do is genetically modify pigs, because pigs, their native DNA code it encodes some foreign antigens that our body will just not accept. But what we were able to do, or what scientists were able to do, is modify these pigs so that that gene was spliced out. I'm drawing a blank on the word, but that gene was omitted, and which allowed then for this first successful pig kidney transplant to be performed. And what they did is they took a brain dead donor. So this wasn't someone who was alive, but they were still on the breathing machine, et cetera. And they got the pig kidney, they transplanted it, and it worked. And it worked immediately. It almost worked like a living donor. And what's surprising or unfortunate is the only reason they had to stop the experiment is because the room which we were doing this experiment, the plastic surgeons had it booked a couple of days later for another procedure. But the point is, you had all these years of unsuccessful xenotransplantation, right? And then you have the pig kidney in September, and then by the end of the year, you had the successful pig heart. That will undoubtedly change the game, because now the supply issue is off the table. Now, this is still a country that's wrought with issues when it comes to disparity. So I'm sure there will be some other challenges that will come up, right? But it will undoubtedly decrease that disparity, because now you have unlimited supply. And then we'll just have to tackle the support system and all that other stuff that still tends to affect patients.
Thank you.
Candidacy, yeah.
Thank you for your question, Dr. Abraham. And thank you again, Dr. Watkins, for being here, for an amazing presentation. And I will, at this time, turn things over to Mrs. Star Fleming and EJ Fleming for closing remarks.
Thank you all so much for joining us today. Thank you, Anthony, my nephew, which I like to say, since I'm younger than him. Erik would have loved this talk, and he'd be so proud of everything that you're doing and everything that the Urban Health Institute and Charles Drew is doing, especially with, inadequate distribution of the vaccine sites. I'm sure he would have been front and center with you all, leading the charge. And, this is such a nice thing to carry on his memory and his work, and, how activated he would have been in this fight, and shedding light. You guys might have been doing this talk together. Erik has always fought for justice and fairness, and even when he was a child, more well-behaved child than this one, he gave away all his toys as a boy to the less fortunate, because he always believed in making sure that everyone had the right to happiness and joy and freedom. So thank you all for joining. EJ, is there anything you want to say if you're done making noise in your hand?
Yeah.
Go ahead, sweetie.
Who are you?
What do you need to say?
I love my dad so much because my mom married him.
Here's the future of medicine, everyone. Thank you all so much for joining.
My office.
We look forward to doing this again and doing more things to, help keep Erik's memory alive and help the community just as he would have wanted. So thank you.
When you go to my office, his picture is on my door.
Oh,
And
thank
that
you.
picture stays
Mine
there as long as I'm at Drew.
No, wait. Nope.
Thank you.
I missed him so much. You know that.
Mine's next to the door.
That's where your picture is. Yeah, that is next to the door. We keep him in our hearts, and his memory is strong. So thank you all so much. And thank you, Kiosha, and everyone for putting this together. Anthony, Caroline, Dr. and Mrs. Fleming, the OG Mrs. Fleming. Thank you very much.
Thank you very, very much, Star and EJ. Thank you to, yes, Dr. Fleming, to Professor Kathy Fleming, to Dr. Watkins, and to our Fleming family joining us, to our CEU family. We just thank you for taking time out to honor Dr. Erik Fleming today. We hope that you all have an amazing rest of your day, basking in Dr. Erik Fleming's legacy. Also, rest of your weekend, and we will see you all next year for this amazing lecture. Take care, everyone. Thank you.